morning everybody. Today we are discussing about the malignancy part 2. In this topic mainly we are discussing about the staging of the organ, how can we manage the stages of cancer, and what are the various methods for treating the cancer, and what are the types of necrotizations, levels of lymph nodes in the malignancy cases. So we already know about the cancer. Cancer of the head and neck is the sixth most common malignancy, and it's most complex cavity for the small cell carcinoma of the upper aortic tract. Small cell carcinoma of the old cavity have a distinct protection of the lymphatic spread before systemic metastasis. From the old cavity, it can spread to the lymphatic drainage. So, one of the cervical lymph nodes plays an important role in the management of this squamous cell carcinoma, the old cavity. So there are two important aspects. One is the clinical evaluation of the lymph nodes and the protection of the occult neck disease in the native neck. So what are the levels of lymph nodes in the oncological aspect? Level 1 means the first one is the submental, that is all within the triangular boundary of the anterior belly of the digestive muscle and the hyoid bone. 1D is submandibular within the boundaries of the anterior belly of the digestive muscle, styloid muscle, and the inferior part of the level that is divided into two angles on the upper shoulder. Located around the upper third of the interjugular vein, the adjacent spinal accessory nerve. 2A means located anterior to the spinal accessory nerve. 2B is located posterior to the spinal accessory nerve. Level 3 is the middle jugular, that is located around the middle third of the interjugular vein, the inferior border of the hyoid bone and inferior border of the cricoid cartilage. Level 4 is the lower jugular, located around the lower third of the interjugular vein, extending from the inferior border of the cricoid cartilage of the to the clamp. Level 4 is the posterior triangle located along the lower half of the transverse cervical artery, includes the supraclavicular lymph nodes. Level 6 is the central compartment, is the pre-laryngeal, peritracheal, paratracheal, and the tracheal esophageal groove. Boundaries of hyoid bone to the suprasternal notch between the medial borders of the carotid sheath. Level 7 is the supraomohyoid in the anterior superior mediastinum of the tracheal esophageal grooves from the suprasternal notch to the innominate artery. So mostly level 6 and level 7 lymph nodes that are not generally dissected in the all cancer patients. That mostly seen on the trachea, or see on the thyroid glands, like that, mostly affected. Level lymph nodes from the 1 to 3 that are called the sentinel lymph nodes, or first confined lymph nodes of the all cancer. So mostly, if you see in the all cavity, the first stage of cancer, mostly the level from 1 to 3 from the affected. This is a diagram presentation showing the levels of the lymph nodes. Anterior belly of the triangle, posterior belly of the triangle. So when after the lymph nodes, we are classifying for the neck dissections. In 1991, they are divided into R&D, modified R&D, type 1 to 3, selecting like a supraomohyoid, lateral, posterolateral, anterior, and extended neck dissection. After that, in 2002, it is modified into R&D and R&D, and selected dissection is depreciated with the use of personas to denote the levels or sublevels removed and extended neck dissection. So that means mostly lymph nodes will be low, sometimes we will remove some structures also. So the lymph node classification of the DOSAK protocol, level 1 means the nodes of the facial vein overlying the mandibular body. Level 2 is the nodes between the thyroid cartilage and the mandibular border. Level 3 is the lymph nodes between the alternate two sternocleidomastoid muscles. Level 4 is nodes of the lateral triangles, posterior triangle. So the type of neck-dissection for the book DOSAK protocol, Supraomohyoid neck dissection is one of the old lymph nodes and intermittent fat tissue from the submandibular triangle, including the salivary glands, the middle because of the mandible, and the lower part of the parotid gland. and anterior and posterior belly of the diagnostic are involved depending on the location of the intraoral lesion. The type of neck dissection may be conservative or functional neck dissection. It is there is the removal of the lymph nodes from the lateral cerebellum and the area of the sternocleidomastoid. Sometimes the preservation of the sternocleidomastoid, blastoma, IJB, and spinal accessory nodes. In R&D, removal of the all tissues from the neck above the cervical deep cervical fascia except common artery, artery, and the skin. So what do you mean by radical neck dissection? It's a block dissection of the regional lymphatics and the primary malignancy was necessary for the effective management. The block dissection included lymph nodes from the level 1 to 5 of the neck. So the cerebromuscular muscle, IJV and spinal accessory sometimes so depends upon the initially from the both of the neck and the nodes of the neck. So there are a lot of incision used for the radical neck dissection. Schumacher, McAfee, Corney, hockey stick, Hackey Martin, Dryad, extension loop, spawn, zigzag incision. Is a diagrammatic representation showing the types of neck dissection. Mostly the Schumacher and Corney are almost same. It's like a Y-shaped incision, and Dryad also is a shape of Y. So McAfee, you can see there are two horizontal lines, and they are both tunneling. Then they remove the lymph nodes. This is the same incision, more for incisions, because if you remove the structures from the neck, so we have to reconstruct that area using petralis major flap. So we will rotate this flap to the neck area. You can see the diagram how they will rotate. Sometimes they will do tunneling. In the second diagram, you can see they will tunnel to the McAfee because the incision will place like a McAfee and tunnel to the that area. So R&D considered two radical technique for the elective use and substantial morbidity shoulder syndrome. That's called mainly depends due to the neck decisions, pain and decreased range of abduction in the shoulder according to the R&D due to the sacrifice of the spinal accessory nerve. Already we told in sometimes in R&D we will remove the spinal accessory, sternocleidomastoid, IJV, all these things. So that's happened the shoulder syndrome. Maintain ongoing safety while also reducing the morbidity of the RNA. The excision of the old lymph nodes from 1 to 5 is totally removed by the RNA with the preservation of one or more non-lymphatic cells such as like the sternocleidomastoid, spinal accessory, and IJV. MRD type 1, that means spinal accessory preserved. Type 2 is spinal accessory and IJV preserved. Type 3 spinal accessory, YJB, sternocleidomastoid also preserved. That means from level 1 to 5, all the lymph nodes will be removed and will preserve all the three structures. That means type 1 spinal accessory, type 2 spinal accessory with IJV, type 3 spinal accessory, sternocleidomastoid, and the IJV. Selective neck decisions. They are selectively removed from the cervical lymph nodes. Supraomohyoid is the most commonly performed. Level 1 to 3 are removed. Anterolateral means from the level 2 4. Posterolateral level 2 to 5 are removed. So supraomohyoid means from level 1 to 3, anterolateral level 2 to 4, posterolateral from 2 to 5. Removal of the lymph nodes from 1 to 3. while preserving is necessary IJV and sternocleidomastoid. So consider to the ideal solution for the dilemma regarding the management of the nodes of the neck. Address the lymph nodes in the occult stage from level 1 to 3 of central lymph nodes. I already mentioned from 1 to 3 most lymph nodes are affected in the oral cancer. Some recent advances suggested the efficacy of selective dissection with the post-op radiotherapy in the management of the patient with the nodes in the neck. That means if the nodes are positive, then definitely go for the radiotherapy also best treatment. Some suggest the SND to include the level to 4 understanding of the neck, especially the cancer of the lateral border of the neck. So if the patient have the lateral border of the neck, then will be high suspect of the level 4 lymph nodes also infected. So we'll remove the level 4 also. Extended neck decision. While intermediate nodes are not involved in the standard neck decisions, are involved by the tumor. When the site of primary tumor is so near the nodes that cannot be resected other than the continuity. When the exposure required to resection of primary as a part of exposure required, the neck decision is common. Sometimes if the some cases when the dissection will be removed, sometimes the tumor size is extended to the other area also. No? Then we will extend the neck dissection also and remove the other parts because we want to remove complete of the what are the complications we can see in the neck dissection cases? Mostly we can see the chest infection, thoracic fistula, acute fibrinolysis, vascular access, that means carotid blowout, cerebrovascular hemorrhage or thrombosis, venous thrombosis. Mostly the neck dissection after that there will be high sensitivity of the chest infection will be there, and we are cutting some dysphagia. Also there will be carotid blowout, cerebrovascular hemorrhage also will be there. Mostly sometimes because there will be an opening from the oral cavity to the neck. So if you are not doing the complete fistula, what will happen? There will be fistula to the neck as in so all the patient is taking the food, everything that will goes to the neck region. That means dissected neck area. So that will leads to infection, and there will be sometimes first discharge. Everything we can see. There are uh, around 100 cases, might be around a few cases there will be chance because according to the severity of cases, with the modified neck dissection also we'll remove the sternocleidomastoid IJV, spinal accessory, everything. What will happen? We will closure from the oral cavity and the neck dissection, watertight closure. Sometimes if there will be opening in the oral cavity, the food will stack and there will be pus discharge from the neck dissection also. So we will again open up and debride that area and put a watertight closure in that particular point. Then wound breakdown and the fistula, intraoral resistance and flap necrosis. So there will be high chances neck wound resistance and the skin flaps necrosis. And there will be personalities failure. Difficulty in swallowing is the most common thing because if the patient having C on the buccal mucus or C on the lateral part of the tongue also, we'll cut it off, we'll remove that area also, and the patient having difficulty on the swallowing the food. That is a common problem. And the patient prognosis after the neck dissection is not at all good. There are a lot of complaints patient can. Already understood. In the case to case basis, the neck dissection will be changed. If there is a small C on the oral cavity, we remove only 1, 2, and 3. If the C on the tongue, like that, might be we are suspecting the level for lymph nodes also. Because if we can never go for the second surgery also. So we will send the patient's lymph nodes for the biopsy. In patients with a pathologically proved occult neck disease, failure rate depends upon the number of positive nodes and the presence of extracapsular spread. When post-op radiotherapy is added to the scenario, failure rate drops depending on the extent of the nodal metastasis, delaying elective surgery of the nodes of the neck, adapting the weight, and watch approving the nodes of a full hardly in most cases. When the patient clinic with the patient having on the buccal mucus or tongue anywhere. So what first we'll send the patient for the clinical examination, assessment of the nodes, everything, where the nodes involved, everything we check. After that, we will take a specimen. Uh, what type of C is it? Then after that, if you're going for the neck dissection, what are the areas involving? We will take it out. If you're not taking out the complete removal of the lymph nodes, there will be high susceptibility of the recurrence will be there. So once if you have done all the treatment after 2 to 3 months, again the patient having remains, that means there will be high failures of the treatment. So we will do the complete removal of the tumor. So after this treatment, definitely depends upon the severity. We will send the patient for the radiotherapy. So we can reduce the maximum uh, positive of what recurrence we can reduce. Otherwise, there will be high chances of recurrence. The question patient with the palpable cellular metastasis from 1 to 4 are the highest risk. Most prevalent operation from type 1 malignancy because the fact that even palpable nodes are smaller than 3 cm in diameter have a substantial incidence of the extracapsular spread of the disease. And solely functional neck dissection is probably contraindicated for the management of the nodes related to the oral cancer. Functional neck dissection, we'll never do it. Mostly MRD selected neck dissection, mostly supraomohyoid neck dissection, like that. In patients with the clinically palpable neck disease, the results of type 1 MRD followed with post-op radiotherapy, that is very important. MRD with the post-op radiotherapy depends on the bulk of disease in the neck, the presence of extracellular spread in the lymph nodes, and a radiosensitivity of the metastatic disease remaining in the neck. We're going to remove the going for the neck dissection. We remove the sternocleidomastoid, submental salivary glands, spinal accessory IJV. we don't know we the complete removal of neck dissection we done. So we will remove the maximum amount of spread of surfaces. We'll take it out, and the remaining part we can treat with radiotherapy. So we'll send the patient for the oncologist and to appropriate to preserve the cranial line. Sorry, number 11. This is very important. If the patient, after our all surgery part is over, we will send the patient to the oncology, and depends upon the oncology surgeons, they will mention about the patient need therapy or not. Therapy. Separate distinction between the muscle and seems horizontal perform. This is most of the cases. Supraomohyoid dissection should be performed from T1 to T4 tongue cancers. That's important. Mostly T1 to T4 cases, and where is the pulmonary and lymphatic emanation of the primary system. Express and local and regional flaps in the maxillofacial region. Flaps is the movement of the adjacent skin and subcutaneous tissue from one location to another with a direct vascular supply. That means we need the vascularity on the flap. This movement occurs by either of sliding movement, advance or rotation, or lifting movement. These are the common rotation movements we use for the flaps. So, what's the need of flaps? Contouring or resurfacing of the defects, closed exposed surface, carotid skin defect, create resected spots, improving functional by providing tissue bulk, bring healthy tissue into defect site. So if the patient is going for the C on the cheek, C on the neck region, there will be defect will be there after the excision of the lesion. So we want to reconstruct that area using with the flaps with the vascularity. It is not like a normal skin graft. We are taking the flaps with the but that means the muscles will be there, and we will taking with the artery and reconstruct to the surgical site. So what's the classification based on the blood supply? Called a random axial based on the location, local, regional, and free. Based on the type of tissue, transform the mucosal skin. That means cutaneous, facial, cutaneous, muscular, and osteomyelitis. That is types of flap. Classification: local, regional, and free. Cutaneous and facial cutaneous, muscular and muscular based on the vascularity, random pattern, and the mucosal. These are type of the flaps commonly used. Doctor flaps, no, we are taking the rotational flaps. Mostly, I already showed in the diagram that if the patient having the neck dissection, we are using the McAfee with the pectoralis major. Sometimes we will take from the flap, that is a flap we are taking for the oral cancer, that is called a radial forearm flap, like that. Rotation flap, advancement flaps is a plastic buccal fat pad that we are taking from the buccal pad and to reconstruct the cheek region. Palatal flap, rotation of palatal flap. Muscular is the tongue flap, we will take it out. Facial cutaneous is label and the forehead flap. Regional flap like a sternocleidomastoid, that is muscular flap. Deltopectoral flap, that is facial cutaneous regional flap. Pectoralis major myocutaneous flap. Trapezius flap as muscular flap, masseter flap muscular, temporalis muscle muscular, latimus dorsi muscular flap. Mostly on the neck dissection they are using this sternocleidomastoid sternocleidomastoid flap, and caliper and pectoralis major. Sometimes we using that submental artery flap, that below the lower part of the meatus we using the submental artery flap. The free flaps we are taking from the radial forearm. That already mentioned. Radial forearm will take out the uh, that type of flap. We will take it out. Now we will anastomose. It's a called microvascular surgery. We will take it out the radial forearm to the brain. We will take out the whole cavity and most the artery and the facial vein. Then lateral arm flap, lateral thigh flap, anterolateral thigh flap, rectus abdominis flap, latissimus dorsi flap, gracious flap, temporoparietal facial flap, fibro-occipitalis, iliac, scapula, metaphyseal, rape, jejunum, omentum, gastromentum. These are the lot of flaps we can take out to reconstruct the uh, reconstruction area. So that means if it is coming with the CA, we are taking out the uh, structure from the anterior. That means there will be defective area. So we have to reconstruct that area with the flaps. But the only thing, if you want to reconstruct the flap, you must counter check. There will be no any recurrence will be there on that area. If there is a recurrence, the flap also will be chance of become mesothelial malignant and remove that flap also. So that is very important. The topic regarding about the malignancy. So in this, mainly we are discussing about the uh, what are the levels of lymph nodes, level 1 to 5, what are called single lymph nodes. Mostly most of the all cancer involving what are the levels 1, 2, 3, that is all single lymph nodes. And what are the types of neck decisions we are using? So SND, MRND, RND, and SND neck decisions. What are the advantage? MRND, what are the structures you will prefer? That is very important. And where we do the neck decision, if the patient is having a C on the tongue or C on the buccal or C on the palate, so we need or not depends upon the uh, mostly if they see on the tongue, we will definitely go for the neck decisions. If see on the buccal mucosa like then neck decisions, might be we can do using the radiotherapy. And where we using the flaps, that also is very important. What are the types of flaps?